Ladies and gentlemen, hello and welcome to the American Lung Association Patient and Caregiver Support Series. The topic for today's discussion is COPD, Support for Today, Solutions for Tomorrow. As a reminder, all telephone lines are on listen-only mode. If you are on the web, you may type in any questions you have using the chat box on your screen. If you need any assistance during the call, including how to join the web portion, please press *0 on your telephone keypad to speak to an operator. Our moderator for today's discussion will be Kristen DeFolio, Assistant Vice President of the American Lung Association. I will now turn the meeting over to Ms. DeFolio to begin. Please go ahead.
Thank you. Hello and welcome to everyone. We're very excited to have you all here. This is our first Patient and Caregiver Support Series discussion. We hope it will not be our last. We have a great turnout today, and we're really excited to be presenting you with information on a topic that is near and dear to our hearts as well as it is to yours, COPD, Support for Today and Solutions for Tomorrow. I'd like to introduce you to our moderators for today. That would include myself, as well as Elizabeth Lancet, who is our Assistant Vice President in the Research Division of the American Lung Association. Why did we choose this topic to bring our first Patient and Caregiver Support Series to you? Well, it's because COPD is a growing problem in our country. You are not alone. We want you to know that. If you are someone who is suffering from COPD or a loved one that is caring for someone with COPD, there are many out there like you. There are 15 million people currently diagnosed with COPD in our country, and up to 24 million with impaired lung function that unfortunately have not yet been diagnosed and received the treatment that will help improve their quality of life. As the baby boomer population enters its golden years, COPD is expected to become an even greater issue. And the problem with this is that isolating and diagnosing COPD is often quite difficult, in part due to some difficulties with not having good enough testing diagnostics in the primary care setting, as well as the fact that many people are not diagnosed, especially those under the age of 65 and women. One of the key tests for testing for COPD is the spirometry test. Many of you may never have even received this test, and some primary care physicians are not well trained in making sure that this test is delivered and used to test for COPD. Finally, there is the influence of stigma. Unfortunately, COPD is often labeled as a smoker's disease, and people see it as something that is brought on by the person who is afflicted by COPD because of having smoked for many years. Regardless, this is a disease that is debilitating and has far-reaching impacts on individuals and their families, and no one should have to suffer in this way. So we are here to help. Joining us today, we have a special guest speaker to talk to you a little bit more about some of the new findings that are coming about in the research field and to show you and provide you with some hope that there are new and exciting treatments coming down the line. Dr. Joe Ramsdell is the professor and division head of general internal medicine for the University of California at San Diego. He is an internationally recognized leader in pulmonary disease and clinical investigation. In 1985, he organized and still directs the UCSD Clinical Trials Center and Airway Resistance Center, with a state-of-the-art research pulmonary laboratory that's used to investigate pulmonary physiology, function, and lung metabolites. He directs a staff of 2 pulmonary physiologists and 4 trained study coordinators to implement all facets of these clinical trials. He has been principal investigator on multiple National Institute of Health and National Heart, Lung, and Blood Institute grants. These include the NIH-sponsored Clinical Research Network 2 and the NHLBI-sponsored COPDGene trial, as well as our own American Lung Association-sponsored Asthma Clinical Research Center. Dr. Ramsdell was the founding director also of the geriatrics program at the Department of Medicine at UCSD. Please join me in welcoming Dr. Ramsdell.
Hello, Dr. Ramsdell. If you can unmute your line, please. by pressing star 1.
Thank you very much. We're off to a great start here. That was a wonderful introduction, Kristen. I especially appreciate the way you emphasized the importance of smoking and the concern about stigmata in terms of, or stigma in terms of COPD. It is important to kind of understand what the current thinking is in terms of how cigarette smoking and other types of irritants can cause COPD. The reason for this is if we're really going to understand how the treatments that we have work or how we believe they work and how researchers are now looking at developing new treatments for COPD, we have to have some idea of what's going on in your lungs with the disease. This slide shows two cartoons that make this point very well. If we can look at the one on the left, it starts with cigarette smoke and other irritants. Now, for all practical purposes, we're talking about a disease of cigarette smoking, and I often joke with my colleagues and the students here that if we could come up with one perfect treatment for COPD, it would probably be some kind of a virus that would wipe out the tobacco plant. Without tobacco, in the United States, COPD would be a very, very rare disease. Now, in other parts of the world, where they use open fires to cook inside or where there are exposure to industrial pollutants at a very heavy level, people can also develop COPD. And we're beginning to learn that there are people who have genetic predispositions who may be developing symptoms at a much lower rate than most folks. But for the general population, we now understand that if you smoke, you have a 1 in 5 chance of developing COPD. Why does this happen? Well, again, referring back to that cartoon, cigarette smoke we know has an interaction with two important classes of cells. On the far left, you'll see epithelial cells. Now, these are the cells that form the lining that coats the airways. Remember, our lungs are like an inverted tree. There's a series of pipes that go down from our mouth and our nose into the very far reaches of our thoracic cavity of our chest. And they end in little sacs called alveoli. The lungs really have two simple jobs. One is to get the good air in down to those alveoli and get the bad air out. COPD interferes with both of those things, and it makes it difficult for people to breathe and to maintain the amount of oxygen in your blood. It does this, to begin with, when the cigarette smoke comes into contact with that layer of epithelial cells that lines this series of tubes. Think about what happens in your nose. If you're getting over a cold like I am, you can go from breathing perfectly clearly through your nose to having your nose almost completely occluded. That's because when the virus interacts with that membrane in your nose, it causes a release of a lot of chemicals. We call them cytokines and chemokines. These are the way that cells talk to each other. And those chemicals tell your body that you're having an infection, and they cause the blood vessels there to dilate, and they cause the influx of a number of cells, such as lymphocytes and macrophages, which are very adept at destroying disease cells, destroying viruses, or destroying bacteria. But in the process of doing this, these chemicals cause swelling of the membranes in your nose and make it difficult for you to breathe through your nose. Let's think about what might happen when those same viruses, or when chronic cigarette smoking sets forth the same cascade by irritating the epithelial cells. What you can see is the epithelial cells release these chemicals, and they recruit lymphocytes and other cells from the blood, as well as macrophages, which come out of the blood and live in the alveolar space themselves. Now, these cells are originally designed to fight infection, as we discussed. But what happens with chronic cigarette smoking is that all of these chemicals that these cells would normally release, which are so important in fighting infection, now are kind of going on at a low-grade level. So instead of a process like a cold where you have swelling in your nose that comes and goes away, we have this chronic low-grade process. So lymphocytes, neutrophils, and the macrophages release a number of enzymes, such as proteases. And these enzymes and cytokines lead to the destruction of the alveolar wall and to more swelling in the airways and mucus hypersecretion. Kind of think of it as just what happens with a cold. We can then see the consequences of this when we look at the next cartoon on the right. There you see what a normal airway looks like in a very terminal part of your lungs. What you see in the blue areas is air, and then you see that epithelial cell around this little airway in cross-section. That's a normal airway, but what you can see as a result of COPD is that you get mucus hypersecretion, so you get the airway itself becomes occluded with mucus that's been stimulated by these chemicals. You also see that these chemicals result in a breakdown of the little walls of the alveoli, so that instead of nice, clear, think of them as small balloons across which oxygen can go into the blood and carbon dioxide can come out, we now have a loss of that and a loss of the lung elastic recapilla. We also see that there's swelling around the airways, so that instead of a nice, large airway to breathe through, we've got this small, occluded airway, which makes it difficult to breathe. Think about the difference between breathing through your mouth and breathing through a soda straw, as well as creates a lot of sputum and mucus. Okay, so I spent a lot of time on that because if you think about this process, this is what informs the way we treat disease. And go ahead to the next slide. So the current recommendations for treating this disease are understanding its causes. So smoking cessation is absolutely important for everybody. And then keeping up on what the latest immunizations are, getting your flu shots, exercising regularly, good behavior, avoiding air pollution, these are all important. The next level of drugs, as severity gets higher, and we have more and more trouble with airways obstruction, are bronchodilators. These are drugs that cause relaxation of airway smooth muscle, opening up the airways so that it's easier to breathe. Then inhaled corticosteroids are used. Now, these drugs act by reducing the swelling itself, and they may or may not be effective in your day-to-day life, but what they have been clearly shown to do is to reduce the number of exacerbations that you'll get. Pulmonary rehabilitation comes next after these mainstay medications. Pulmonary rehab is very important for getting the most out of your body, given the damage that you have in your lungs. So if you can't get as much oxygen into your blood because of the loss of these alveoli with COPD, pulmonary rehab teaches your body how to get more out of the oxygen it can get. It also reinforces behaviors that are very helpful in clearing secretions and avoiding infections in the future. If that is, as your symptoms increase, then it may be necessary to wear oxygen on a partial or constant level to make up for the loss of this alveolar surface area that is a consequence of the COPD process and the emphysema that goes along with it. Finally, for selected patients, lung reduction surgery may be a helpful approach. This is for a small subset of patients. So this is kind of where we are now. Can we have the next slide? Looking ahead at what the progress, the natural history for smoking is explained by this slide. This is a remarkable cartoon that was really developed by researchers 60 years ago in England. And what they noted is that there's a gradual loss, and FEV1 is just the amount of air that you can blow out of your lungs in 1 second, blowing as rapidly as possible. So it's a measure of airflow obstruction. As we can see, there's a gradual decline that's a normal part of aging that occurs in everyone in our airflow obstruction. But with smoking, in the one out of 5 people who's susceptible, this is rapidly speeded up. So think of it as almost premature aging of the lung. Normal lungs should last a lifetime, so that in the absence of COPD or other diseases, a non-smoker will rarely have any respiratory complaints. But a smoker will start to develop symptoms, dyspnea on exertion, cough, frequent colds and bouts of bronchitis, when a non-smoker doesn't. Those symptoms gradually progress to disability, where you're unable to carry out your normal activities of daily living, and can eventuate in death as a result of the smoking. So this is the the battle that we're fighting. This is what our research is coping for, is to prevent the progression and to try to move lung function back up to the normal non-smoker's curve. Can we have the next slide? We've talked a little bit about how we do that in 2 slides ago, but we're really looking at 2 types of medications, bronchodilators and corticosteroids, and I wanted to spend just a few seconds talking about that. Bronchodilators may reduce some of this swelling and inflammation that we talked about, but what their major role is opening up the airways by reducing smooth muscle obstruction and making it easier to breathe through. Again, I'll use the example of breathing through a soda straw versus breathing with your mouth wide open. A bronchodilator will hopefully relieve the sensation of the shortness of breath that goes along with bronchoconstriction, just like taking away the soda straw when you're trying to breathe. What is recognized is that bronchodilators can significantly decrease symptoms and can significantly decrease the number of exacerbations and hospitalizations. What they will not do is change the curve that of COPD that we saw in the last slide. There's a number that are available, including short-acting, and many of you are familiar with these, albuterol, levoalbuterol, and ipratropium. These are rescue medicines for when you have symptoms. And then there's long-acting bronchodilators, salmeterol, formoterol, tiotropium, aclidinium, theophylline, and these are in the bloodstream for a long time, so they help prevent symptoms and give you more long-lasting control of airway caliber. Next slide, please. And then the other class of drugs we talked about are corticosteroids. They don't really cause bronchodilation by relaxing smooth muscle, but they're very effective in reducing the inflammation and the swelling that goes along with it. That increases that poor shriveled airway that we saw in the other slides and helps, again, breathe more freely. We know that it can improve your lung function a little bit. We know that it can decrease symptoms. And corticosteroids are also effective in reducing hospitalizations for exacerbations. So they can be very important. They can be given orally or inhaled. In general, we only like to use oral corticosteroids during the course of an exacerbation and then for a very short period of time. That's because they have a lot of side effects associated with them. And many of you know the medicines we've got, beclomethasone, fluticasone, budesonide, and then there are combinations of bronchodilators and corticosteroids that are available. Advair, Symbicort are the ones that come to mind most regularly. These can be very effective in treating symptoms of COPD. But again, neither corticosteroids nor bronchodilators will change the underlying course of the disease. Could I have the next slide, please? So what other drugs are available? Well, you may have heard of roflumilast, which is a new PDE4 inhibitor that's recently been released, and its main indication is to prevent exacerbations. So it's kind of like taking Lipitor or a statin to prevent a heart attack. You will take roflumilast chronically to try to prevent exacerbations. This is most effective in people who have more severe disease and who have had 2 or more exacerbations in the previous year. Finally, mucolytics are being used a little bit to treat this. The idea here is that these may make the mucus easier to cough up. When you look at them in careful controlled studies, though, their real usefulness in prolonging, in enhancing your ability to carry out daily activities or reducing exacerbations is not clear, but many people will try them to see if they can make it a little easier to breathe throughout the course of the day. Next slide, please. Pulmonary rehabilitation we already talked about, very important in terms of allowing you to make more with what you've got, reduces shortness of breath, increases your exercise performance, improves quality of life, reduces healthcare utilization. The last one is kind of a geeky approach. The next slide, I think, puts this into a more meaningful frame. What it shows is that the main cost of hospital expenditures is hospital admissions, and this slide shows the percent of patients who have a hospitalization over the course of a year, comparing the pulmonary rehab group in the gold with usual care in the blue. And as you can see, there's a significant reduction in hospital admissions and an important reduction in emergency department visits for an exacerbation in patients who have gone through pulmonary rehab. I think this is probably the most important benefit of pulmonary rehab at this time. Well, where are we going with this? Could I have the next slide, please? Oh, I'm sorry. I forgot to say that oxygen and surgery are important options for patients with COPD. The need for oxygen is determined by what your blood gas or the amount of oxygen in your blood. And as I say, there are a small group of patients in whom lung reduction surgery may be useful. Finally, lung transplantation is increasingly being used to treat people with COPD. The problem is donor lungs. So this is not an ideal option. The other caveat about lung transplants is COPD is generally a disease of older age, and most people are hesitant to transplant somebody who has multiple other diseases. So that it is an option, but it's certainly not one of the best. Okay, now let's see the next slide. So where are we going in the future? Well, the first thing I want to do is put in a little plug for some of the networks that are sponsored by the Lung Association and the National Institute of Health that are trying to attack this problem in an organized way. The COPD Clinical Research Network, the COPDGene Network, which we're part of, which includes 20 institutions across the country, and the ALA Asthma Clinical Research Centers, which are now going to be looking into understanding the treatment for smoking and asthma, too. I'm going to make a big pitch at the end of this talk for everybody participating in clinical research. If one of these research centers is in your region, and you can find this by going on the web and looking for them, I would strongly encourage you to get to know them and see if there's any studies they're doing that might be appropriate for you. Can we have the next slide? Well, what are investigators looking at right now? Well, there's a couple of things that are very interesting. There's new information that suggests that low-dose continuous use of certain antibiotics like azithromycin or scheduled intermittent use of other drugs like fluoroquinolones. You may think of azithromycin, you may know it as Zithromax. Fluoroquinolones include things like Cipro, drugs like that. Now, it is not clear that these are useful at this time, but what they may do is actually change the way that these blood cells release these inflammatory mediators and reduce the inflammation that way. There are new combinations of drugs coming out, corticosteroids with drugs like tiotropium, and bronchodilators combinations. All the bronchodilators don't work in the same way. This is an area of active research right now, and you should expect to see new things within the next few years, maybe sooner, as these drugs go through the research pipeline and start to become available. Protease inhibitors have been used for patients with specific genetic types of emphysema, specifically alpha-1 antitrypsin deficiency for years. And there may be a role for them in the future, but they are very early stage yet, and it'll be many, many years off before those are available. Again, they block these enzymes and chemicals that cause the damage in the lung. Statins, which also have an anti-inflammatory effect, things like Lipitor, are being studied. Vasodilators like Viagra, sildenafil, are being looked at because they have a beneficial effect on pulmonary blood flow. Anti-leukotriene agents, other anti-inflammatory agents are being looked at. These are commonly used in diseases like rheumatoid arthritis and psoriasis, but have had mixed results in COPD. Finally, way on the horizon are growth factors, which can actually maybe help heal the lung and grow new lung tissue. Can I have the next slide, please? Pulmonary rehabilitation, there's a large study ongoing now, looking at the LOT trial, which is looking at chronic oxygen use. New studies are trying to better identify patients who will benefit most from pulmonary rehab. The effects on other aspects of life, like depression and quality of life, are being looked at. Home-based training, particular muscle training techniques, and better ways to use oxygen are being studied. finally, new approaches to surgical changes that won't involve maybe open surgery, bulectomy, removing specific parts of diseased lung in certain patients. And then there are bronchoscopic things, pulmonary stenting and bronchoalveolar fenestration procedures. What these do is actually try to correct some of the defects of chronic obstructive pulmonary disease through a bronchoscope. New wave stuff very early on, but there's some interesting research coming out on that. Next slide, please. So I'm getting near the end, but I want to leave you with a couple messages. The only way that we're going to bring these new drugs into line to join the drugs we have is by doing good clinical research. It not only identifies successes, but it also identifies failures. Infliximab is a drug that's used in rheumatoid arthritis very effectively, but has no real beneficial effects in COPD. That was shown in a very important trial several years ago. In addition, other drugs, retinoids and others that have been suggested to be effective in regrowing new lung haven't quite panned out. The only way we knew this was to do clinical trials. Finally, I want to just give you a little update on COPDGene, which is a very large trial that is identifying new candidate genes so that we're starting to be able to maybe identify who is going to be that 1 in 5 person who develops COPD, as well as giving us a whole new way of looking at the disease itself. Could I have the last slide, please? So in conclusion, we've reviewed the drugs that are effective now, but I've tried to make the point that none of these drugs are what we call disease-modifying, in that they don't heal, they don't change the course of the disease, they mainly improve symptoms and your ability to function while you have the disease. There are a number of other approaches aside from drugs that are being looked at, but all of these require the active participation of physicians, nurses, and patients in clinical research if we're to make progress. So thank you for your attention, and hopefully we'll have some questions at the end.
Well, thank you, Dr. Ramsdell. That was quite interesting and thorough in what's going on today in COPD research and medicine. So we're going to take another step, and we're going to talk about what the American Lung Association can do for COPD patients and caregivers. Knowing about COPD and how to treat and manage the disease can help you feel more in control and improve your quality of life. The Lung Association has many resources to assist you in that. The first type of support we provide is self-management tools. One of the most important things you can do if you have COPD and if you smoke is to quit. The American Lung Association offers the gold standard of smoking cessation programs known as Freedom from Smoking. The Freedom from Smoking program is designed to help smokers gain control over their behavior and can be completed in person or online. The in-person group clinic includes 8 sessions and features a step-by-step plan for quitting smoking and encourages participants to work on the process and problems of quitting both individually and as part of a group. For an online version of our successful program, you can go through the 8 sessions on your own time from the comfort of your own home. The American Lung Association also offers the Flu Vaccine Finder, which searches locations near you offering the flu vaccine. Getting vaccinated each year is one of the most important steps people with COPD can take to help protect themselves from the flu and complications of their disease. The CDC, the Centers for Disease Control, recommends annual influenza vaccination for patients of COPD and residents of long-term care facilities and nursing homes. Additionally, those who come in close contact with COPD patients, such as caregivers and health professionals, should also get a flu shot, not only to protect themselves against the virus, but also to avoid spreading the disease to these more vulnerable populations. In fact, this year, I'd like to give a plug that this is more than necessary, as we are seeing a flu epidemic throughout the country. Lastly, as Dr. Ramsdell alluded to, participation in clinical trials is key. Clinical trials are conducted to collect data regarding the safety and efficacy of new drug and device development. They have a natural place in your care as doctors strive to improve current COPD treatments and search for new and better ones that will improve your lifespan and the quality of life. In addition, patients have close contact to trial physicians, and all study-related care and study-related treatments are provided at no cost to you or your insurance company. We currently sponsor the ACRC Asthma Clinical Research Centers, and as Dr. Ramsdell alluded to, we currently have a trial looking at how smoking impacts asthmatics and others with obstructive lung disease, such as COPD. Next slide. The second type of assistance the American Lung Association provides is providing and hosting support groups with people with lung disease. First, our lung helpline call-in center can answer any of your questions about lung health and COPD. Our call-in center is staffed by nurses, respiratory therapists, and cessation specialists, and is available from Monday to Friday from 7 a.m. to 9 p.m. Central Standard Time. They offer free, unlimited services that can be translated in up to 150 languages. We also offer the My Fighting for Air Community online caregiving coordination service, where family, friends, colleagues, and neighbors can organize support of everyday tasks, from simple household chores to weekly grocery trips. The My Fighting for Air Community is a free, private, online coordination service that includes an easy-to-use private group calendar specifically designed for organizing helpers who want to assist during times of need. Our Better Breathers Club offers the opportunity to learn ways to better cope with COPD while meeting and getting the support of others who share in your struggles. These support groups give you the tools you will need to live the best quality of life you can. They are held in every state throughout the country, meet regularly, and feature educational presentations on a wide range of relevant topics, including how COPD affects your lungs, breathing techniques, talking with your physicians, medication and other treatment options, supplemental oxygen, home health care, lung transplantation, and risk factors for COPD, such as air pollution and smoking. If you feel alone and isolated, these support groups can help tremendously. It feels good to talk with others who understand what you are going through, which has a direct positive impact on your health. Lastly, the American Lung Association offers the Lung Connection online support community. This provides similar support to as the Better Breathers Clubs, but connects people who are facing lung diseases like COPD online from the comfort of their own home. Next slide. Lastly, most recently, the Lung Association developed a COPD action plan, which is a 2-in-1 personal tool that helps patients talk with their doctors to develop a plan that is best for them. With a plan in place, patients will know how and when to take their medicines, when to call their health provider, and when to get emergency care. Copies of this COPD action plan can be accessed on our website or via the Lung Helpline. In conclusion, there are 5 easy steps that you can take today, right now. 1, visit our website, www.lung.org, or call our Lung Helpline at 1-800-LUNG-USA to get more details on the resources I just presented here, including smoking cessation programs, our Better Breathers Clubs, and our website for patient and caregivers. Print out the ALA COPD Management and Action Plan and bring it with you to your next doctor's office visit. From the website or via the Lung Helpline, look up the closest Better Breathers Club meeting and attend. Join the Lung Connection to connect with others going through the same thing. And most importantly, get a flu shot. At this time, I'm going to hand it back over to Kristen, who's going to introduce some special guests with us today.
Thank you, Liz. Well, by now you've heard an awful lot of information, and you're probably, hopefully, excited and feeling very hopeful about the future of dealing with this illness. But we wanted to go a step further and make sure you heard from some people who are experiencing what you were experiencing, and share with you some of the positive experiences that they've had in 2 of the support mechanisms we've mentioned here today, specifically pulmonary rehabilitation and our Better Breathers Club. Today we have with us Bill and Kathy Carroll. Bill is a COPD patient, and Carol is his wife, his primary caregiver. And we also have Beth Slick, who is the Better Breather Club facilitator in Leonardtown, Maryland, where Bill and Kathy participate in these activities. These activities come through the Better Breathers Club established at St. Mary's Hospital in Leonardtown, Maryland, just a few years ago. This program, along with the pulmonary rehab program there, was brought about by an individual's generous donation in honor of his wife who had COPD. They are very lucky to have this program in their community, and they're here to tell you a little bit more about it. I'm going to start off by asking Bill and Kathy some questions just to get the dialogue going. Bill, can you tell us how long you've been diagnosed with COPD, and were you a smoker?
Yeah, I was a smoker for like 50 years, and I was diagnosed in the 80s, the early 80s, with COPD.
Wow, that's a long time.
Long time.
Yeah. But now, how long has it been since you joined the Better Breathers Club and the Pulmonary Rehabilitation Program at St. Mary's?
It'll be 3 years this April. And it's made a world of difference in my breathing, because back 10 years ago, I couldn't hardly do anything. I retired because I couldn't do anything. And I did nothing. I couldn't do anything. I didn't have the energy, the lung capacity. I just didn't do anything. It's like go to the grocery store. I would drive, I'd pull up to the door, let my wife out, and I would go to the park and wait for her to get done. I just didn't have the energy to do anything.
And what kind of a change have you seen since you started these programs in your own quality of life?
In my quality, it's to me, it's 100% difference. I can go to the grocery store. I go on my own. I don't need help. I don't need my wife putting my shoes and socks on for me anymore. I can do it myself. And it all was going to the rehab. What I learned in there, what we do, and it's not only me, it's everybody that goes that you can see the improvement. And the main thing is to go. It's to get up and do it. And then once you do, you feel better. It took a while to turn it around. But it turns around, and it stays turned around when you keep going.
Yeah. Wow. Well, that's wonderful to hear. Can you also speak a little bit to some of I know physically it sounds like you're doing much better. Can you tell a little bit about the support you feel like you've gotten from some of the other Better Breather Club members that you've met?
I didn't quite understand what you meant.
Oh, sorry. I was just wondering, the Better Breather Club that you attend, can you tell us a little bit about how being around those other people has made a difference to you in your overall quality of life?
Well, you can talk to them, and you know they know what you're talking about. You know, it's like it's hard to tell somebody that you can't breathe when they have no problem breathing. You know, it really makes a difference that when you're talking to somebody that's like, yeah, I know what you felt, but I did this, or I did this, or, you know, when this happens, do you press lip breathing? You know, and it really makes a difference to me and the people I talk to, the support, you know, it's the, okay, you know, it gets better. It does get better. And I try to tell everybody that too also. You know, you feel better, you can get around more, you know, it's everything combined.
Now, Kathy, you and Bill have been together since you were teenagers, right?
Yes.
Yeah.
Can you hear me?
Yes, I can. I hope everyone else can as well. So what do you think, what kind of difference have these programs made in your quality of life and your ability to take better care of Bill and your relationship overall?
Is that better?
Kathy, you there?
Okay.
Yes, that's fine. Okay.
Bill and I, the COPD occurs gradually. and little by little you lose more and more. Well, over the years we adapted, not consciously, but maybe subconsciously adapted to the restrictions he started having, until eventually it got to the point where he could no longer do anything he enjoyed. He loved to cook. He loved to fish. Of course, we're in southern Maryland. He loved to crab for blue crabs. And he could no longer do any of that. And it got to the point where, as he said, he couldn't even put on his own socks. He could not hook the small dog up to take her out potty. It's just, he couldn't even cook by himself. I would have to get out the pans for him. I would have to take him from the stove to the sink, whatever. It just really restricted. And we almost got to the point, because if he walked across the room, he would be out of breath. And there is no carrying anything and walking. And as I said, we made the changes, the adapt, and we did to accommodate. And it got to the point where it was basically, this was what it was going to be until he died. And then we get the rehab. And then he starts the Breathers Club. And what he didn't mention, and I think you wanted to know, was in attending the Breathers Club meetings, he comes home, after each one he comes home, and he'll discuss with me different things that he's heard of changes or an easier way to do something, or something new that's there, or how to accommodate something else that you need to do. I mean, it's very informative, and it really does help. And, of course, having other people there that have the same problem or are going through the same thing, it's much easier to relate to what they're saying and to understand it. And then the rehab, oh, my goodness. As I said, I was at the point where Bill did not move. I mean, Bill did not move. We're talking about to walk across a room. He basically was done. And now, just by going, he's increased his stamina, his breathing, he's lost the extra weight, which, of course, takes it off his diaphragm. He can put on his own socks. He can take the dog out. He can go to the store if he wants. It's just so, all those little things that you don't even think about in your everyday life mean so much when they're gone. And now he has so much more quality, and we're just blessed. We are so thankful that this program is available.
That's wonderful. You know, it's so exciting to hear a story like yours. As we're sitting here talking, we've been getting an awful lot of questions through our chat box, and we'd like to have a chance, since our call is coming to an end soon, we want to have a chance to answer just a couple of these questions. You'll still be able to go online on our website, and you'll get some more information after this as to how people can go about asking more questions and staying connected with folks like Bill and Kathy and other people that are in our Better Breathers Clubs and our lung helpline. But I'm going to turn it over to Liz to talk to you a little bit about some of the questions and give you a chance to hear some of the responses.
So if you have a question, please type it into your chat box on the left side of your screen right now. We only have a few remaining minutes, so not all questions will be answered. However, we will be following up with answers to your questions within the next few days. For those listening in by phone, we invite you to contact us on our website or at the American Lung Association Lung Helpline with your questions. All questions will be posted to the website and answered in a few days if we do not answer them here. So the first question we got is actually for Dr. Ramsdell. John Grzmanski has asked, can you please describe the definition of an exacerbation? You mentioned it as an incident that may occur a couple times a year. Well, I thought it was an occurrence that happened quite often. Can you please explain?
Sure. This is a very important part of understanding COPD for two reasons. One, it does look like the more severe you get, when you get an exacerbation, it actually speeds up the rate of loss of lung function. So certainly for serious exacerbations that put you in the hospital, it can accelerate your loss of lung function and your ability to do things. We define an exacerbation in several ways. Mild exacerbation would be an increase in symptoms severe enough so that you start to change your medications other than what you're using, so that instead of maybe using your inhaler once or twice during the day and taking your routine medications, you have to increase the number of rescue treatments to several times a day for several days in a row. This is often accompanied by the need to take either corticosteroids or antibiotics as part of the exacerbation. So that is a mildish exacerbation. A more severe exacerbation is one that might take you into the hospital, and a severe exacerbation is one that would, into the emergency room or cause you to see your doctor. A severe exacerbation is one that would put you in the hospital and may lead to death. Now, those are more or less formal explanations. An exacerbation actually is probably an acute process that sets off these inflammatory mediators I talked about. Most often that's because of a virus infection. And normally people get 1.5 colds a year. Now, I've never understood what a half a cold is, but on average you'll get between 1 and 2 colds a year. And people with COPD, whether it's mild, moderate, or severe, are at risk for that too. And in fact, we see that the average level of exacerbations or colds, of exacerbations in COPD is about the same as the number of exacerbations or of colds in people who don't have it. So we're really looking at between 1 and 2. And most of the treatments we see tend to significantly reduce that by maybe a third, so that instead of having 2 a year, you may go down to just having 1 a year. As a result, you're not going to be at risk for losing lung function as much. How do you know you've got an exacerbation? You're going to cough more. Your sputum will change from clear to colored, either light green or brown. You may have a little blood in your sputum, a little red in your sputum, and the breathing gets much worse. And these changes occur over the course of a day or two as opposed to the slow, gradual change we talked about. I hope that gives you an idea of the way we look at exacerbations, both to do research and in terms of treating people.
Okay, so here's a question for Bill. Were you initially receptive to the idea of pulmonary rehabilitation? I have patients who feel like it will be a dead end for them because they have tried so many things.
Well, with me, no, I wanted to go. I wanted to go because I was doing nothing. And when I started, it was hard because I could barely do anything. But as it went on...
Bill, could you get closer to the phone?
Okay. Can you hear me better now?
Not really.
All right, that's a little better.
Is that better?
There?
That's perfect.
Okay. Now, when I first started, I wanted to go because I couldn't do anything. And it was like, okay, it's because I heard about it through my brother. My brother was in rehab for bypass surgery, and he was talking about a person that was in pulmonary rehab that got away and stopped. He didn't need his oxygen anymore after like 3 months. And he said he felt 100% better. And then when my brother told me about it, that's when I went to my pulmonary doctor and asked him. And he told me St. Mary's had just started one in Leonardtown. And he got me into the program. I went, and within a month, I could feel the difference. And everything picked up, and that was 3 years ago in April, and I still go. And that is the thing that helps. And you can't stop. You just keep going. And if you keep going, it stays with you. If I see people that's gone and stopped, and then they wind right back up where they were, because it just, if you don't keep the change going, then the change is not going to be there. And
Thank you, Bill.
It really works.
Our next question is is for Dr. Ramsdell. I quit smoking 12 years ago, and I was diagnosed with COPD early in 2012. Why, since I quit so long ago, did I get COPD?
That's a great question. Remember that I said that only 1 in 5 people seems to have the right genetic makeup that when they get that smoking, when they get that exposure to cigarette smoke, it triggers this kind of counterproductive inflammatory reaction in the lung. It does seem that if you smoke long enough and you're one of those people, that inflammatory reaction doesn't turn off the way it would if it were just a simple infection. Now, not everybody who has COPD or who smokes has that reaction. So we do believe it's a genetic component, and since COPDGene was started, we've identified over 40 potential genetic link-ups to this. But what basically that abnormal gene causes is it reacts to the cigarette smoke as if the cigarette smoke were something causing an infection. And instead of turning the reaction off when the cigarette smoke goes away, like you would if you got over an infection, the process seems to be self-stimulating, so it continues to go on and on and on. We don't know why that occurs. We do believe that it's related to the genetic problem. So I hope that answers your question.
Okay, so we have another question for Beth.
Yes, actually, we'd like to have Beth talk a little bit about her Better Breathers Club group. There may be some folks on the call who have an interest in starting a group or getting involved as a volunteer in some way. Can you talk a little bit about how the group functions, the Better Breather Club group, and what recommendations you might have for people interested in becoming a facilitator?
Yes. Well, the Better Breathers Club, we function as we have guest speakers come in, and just to give you an idea, we've had TSA, Transportation and Safety Administration, come and talk to the group about safe travels with oxygen and medication and the ins and outs with that. We've had pulmonologists come and speak to the club about COPD, sleep apnea, what have you. So it's a wonderful resource, and the guest speakers we line up are what the club members want. So I ask our club members, what are you interested in learning about? For instance, our February meeting is over asthma with the ALA Helpline webinar system. And we meet every other month. So we'll meet in February, then we'll meet again in April. And in April, we have a guest speaker who is an attorney, and she's coming to speak to us about living wills and advance directives. The club members wanted to know more about that. So our Better Breathers, just to give you some background, was started because when our pulmonary rehab started, we noticed our patients were arriving about half hour to an hour early, and they were just sitting and talking about what was going on in their lives. So we saw that it would be a wonderful resource for them. And it just kind of follows along through pulmonary rehab. We build a cohesive bond, if you will, with our patients, and they become more like your family, and they become family to one another as well. And then we just carry that through with the Better Breathers Club, and it's just a wonderful resource for education, camaraderie. As Bill had stated earlier, as someone who does not have COPD, I can sit and listen and, say, yes, it has to be horrible, but I've not experienced it. So it's easier for them to relate to someone who is suffering from the disease process. So the Better Breathers Club is just a wonderful resource for us to provide education, camaraderie, what have you.
Great. Thank you, Beth, so much. Well, we're pretty much out of time here, but we want you all to know that all questions that we've received through the chat box will be answered. Be on the lookout for an email coming to you after this presentation with answers to some of the more frequently asked questions, as well as links to additional resources. Please, please, please try to complete the survey that we send out, because this will help inform future discussions like this. If you've enjoyed what you've heard here today and found it to be useful, we want to hear from you, and if there's anything we can do to improve, we'd like to hear that as well. A reminder that you can call our lung helpline any day of the week to ask them questions of our registered respiratory therapists and nurses. That's 1-800-LUNG-USA. And also you can go to visit our website at www.lung.org/lung-disease/COPD. All this will be in the email as well. And we want to thank you for taking your time to be with us today. And we hope that we've given you some valuable resources that you can take with you and consider taking some of the actions to help improve what's going on in your life. And we look forward to hearing from you again.
And we thank the speakers who graciously volunteered their time to make this presentation very informative for all of us involved. So thank you, everybody, and we look forward to receiving your questions, and please look out for that email with answers to all of your questions. All questions will be answered and slides will be made available. Thank you.
Thank you very much, ladies and gentlemen. Today's conference is now concluded.